right, great talk, Justin. Only caveat I'd say is I'm 99% in agreement with you, but I think the only thing would be an L5S1 with a bilateral spondylitic defect. There's no FDA-approved device that is standalone anteriorly for that purpose, so I generally back them up. But other than that, I think I agree 100% wholeheartedly with the anterior approach. I think more than 50% of my practice is anterior, and great job. So how many of you guys remember what the Palm Pilot was? All right, okay. How many remember, how long did you actually own one? In your hand, like maybe 1 or 2 years, right? And then what happened after that? What came along? The cell phone, right? Apple, all those kinds of things. So what's happening right now in the world of low back is each of us right now, I think, is almost a Palm Pilot, right? We're about to become moded, if you will, very quickly. And if we don't understand what this new technology is out there, we're going to be the Palm Pilots in the bottom of the box in some family room, as a relic. I think there's this amazing science that's going on right now. So I'm going to kind of show you some stuff now. How many people know the name of the cell that can differentiate into any human cell in the body? One hand in the back. You don't remember? Okay. Not many people do, okay? But there is one cell, right? It's called the mesenchymal cell. If you walk out of here today with one message, understand that this cell is a pretty powerful cell. So I'm going to go through some of the introduction stuff, regenerative medicine topics that are really, really generating a lot of activity these days in the scientific realm of back pain. So the mesenchymal stem cell, not only does it differentiate into any cell in the human body, right? Eye, spine, nerve, bone. It also has multiple different activities, right? Antifibrosis, angiogenesis, antibacterial, chemotraction, da-da-da-da-da, right? So it's a very important cell to understand and know. As far as we're concerned in this room right now as spinal care physicians, the terminology that you should sort of have in your head at this point, if you don't, you probably should. These are sort of the terms. BMAC, right? Bone marrow aspirate concentrate. That's where you take bone marrow out, spin it down, use a portion of that spin down and inject it into the disc, right? Prpp, we're all pretty familiar with that is, right? Platelet-rich plasma. That comes out of the blood. You spin that down once and twice. So it's a double spin. You take that and you can inject that, say, into the disc or other tissues in the body. Then there are these stem cell types of clinics you might be seeing now, especially in California, New Jersey, a lot of the freewheeling sort of centers now with a lot of pain management density. You'll see stem cell clinics, freestanding stem cell clinics, right? They'll take your fat and they'll turn your wrinkles into nothing, right? A lot of these things are a little marginally legal, so you have to be very careful, right? The introduction of a fat stem cell in the United States right now, a true fat stem cell is an illegal activity, right? It cannot be done on a legal basis. So there are certain things you have to understand. And if you're referring these patients to some of these clinics and things like that, you need to know what they're about because not all of them are actually doing things that are legit. And then exosomes, right? Exosomes are these little pockets. They're like power pockets that can break off of a cell that have really concentrated growth factors in them. This shows what an exosome looks like. It's an MSC cell that breaks off, and it's very powerful. And so some people are using these little tiny power pockets to influence regeneration in the body. Platelet-rich plasma, it has a multitude of different cytokines, growth factors, you name it, it has it. It's a very powerful fluid. It's not been studied as much in spine as the BMAC. The BMAC is sort of the gold standard right now as far as, say, what they call stem cell injection, right? Even though it's not a true stem cell. The BMAC is the one that's been studied a little bit greater. You'll see these advertisements in a lot of journals, like for these types of concentrating systems, right? Is this fact or fiction? What is going on here? Are these BMAC and PRPP sort of interventions, are they actually showing promise? So I just was in control, and I know I sent a few of you in this audience a survey to do for the AMA. So I'm on the AMA CPT panel at the federal government level for one of our societies. And I was in charge of actually surveying the entire US as to the utilization of this type of technology across spine surgeries, neurosurgeons, orthopedics, and pain management physicians, right? And so this survey I just completed it this month, and it's interesting when you look at the use. It's actually not, although there are centers that are, growing, the actual utilization is still on a smaller level. BMAC seems to be the one that's being used most because, again, it has most of the scientific data that's out there. And then plasma-rich protein or plasma, is sort of second. It's easier to do. You don't have to actually take a trocar and put it in an iliac crest, so it's easier for the pain guys to do that type of procedure, although pain guys are doing the BMAC procedure in high levels as well. I'm not going to go through all the PRPP types and how you do it, but when you look at the components of the PRPP, this is where you sort of have to have a basic understanding of what's happening. Okay, so pericytes become your mesenchymal stem cells. Some people are calling these mesenchymal stem cells medicinal signaling cells now. It's more of a apropos term for what these cells can do and how powerful they are. So these MSCs are secretory, but they're also have the ability to go to a site of inflammation. So they can sense a skin laceration. They can sense a tendon injury in your medial collateral ligament, Joe Morelli, who's our ski expert today, right, with his knee pain, right? So right now there are some MSCs that are sensing the inflammation in your knee. And those inflammatory markers are attracting these MSCs into the field. And those MSCs are going to contribute to not only activating the healing process themselves, but they're going to activate your own stem cells in that knee tissue, right, to awaken. So your stem cells in your medial collateral ligament right now are awakening, right? And those stem cells are going to heal your ligament injury. Can you hit the play button on there? So this shows you how the MSCs will, this is a video I took when I was at another meeting. And it shows, you can see the small cells, that they actually are moving towards that site, that laceration. So there's a wound there, right? And these small cells will actually migrate into that area. These MSCs will migrate into that area. Once they get in there, they secrete their own healing properties, and they also induce other stem cells in the area to actually heal. And that's how we heal. That's how our bodies heal. Okay, next. Okay, so again, I'm just sort of hammering this idea of MSCs again and how they're activated, what they do, how they activate the healing process. But again, they can differentiate into bone, cartilage, muscle, marrow, tendon, adipose, connective tissue. And so they're a very important cell segment in our body. They also change the entire area around the healing, just like I talked about. Okay, so there's different sources of MSCs, like there's fat, which I talked about. There's bone marrow, placental. You have to be very careful what you read about in here, right? Here, umbilical stem cells, right? There is really only 6 truly FDA-approved, they call them 351s, right? 351s are, there's different ways of approving stem cell technology in the US, a 351 and a 361. There's only 7, maybe 10 351s that are actually FDA-approved. They're live cells, they're cultured cells, right? The umbilical cell systems that you're hearing about now and being pushed to use, there's no live cells in that tissue. Right? There's nothing derived in that tissue that is live. They're all dried up, dehydrated, sterilized. So there's no live stem cells in that umbilical tissue that you're being asked to use. And the same, this is this SVF, stromal material, right? Same thing with the fat. This is what I was telling you. This is the stuff that's being done out in the clinics that is not really kosher. And so if you see this stuff going on in these areas, just kind of stay away from them for now. Okay, bone marrow, this is something that's more relevant to us. We harvest bone marrow aspirate every day. And when we do this, we're actually harvesting these MSC cells. And these MSC cells are very potent. And if you're going to harvest anything and use it in the body with an allograft, the bone marrow aspirate is key. And if you're going to, say some of these tougher multi-level deformity cases where you can't get enough, say, autograft from the iliac crest, right? The bone marrow aspirate is going to be a very helpful item for you. Use that with your allograft, and your healing rates are going to be much higher. Fibrin scaffolds are very potent as well. They are a nice way of promoting cell attachment. And then there are different methodologies for spinning down these materials, the blood plasma and the bone marrow. There's a couple companies that I've looked at, and this life form seems to be one that's very useful. They have great products. Their prices are good. They're a good company to look at if you're interested in doing this. If not, just sort of stick it in the back of your head. But basically how it's done, again, you withdraw the blood, it gets spun down first time, then it's spun down a second time. This is for the PRPP. And then the BMAC is kind of the same idea, except BMAC, when it spins down, you're going to be utilizing a very thin layer at the very bottom of that spin down. It's not the whole plasma. So it's a very, very thin, it's like 2 cc's of the entire spin down that you're going to use. And this is just some of the data. This was a PRPP management in chronic low back pain. This was a meta-analysis that came out this year recently. If you look at the meta-analysis that are out there, those individual studies are not as high. They're not 1A, they're not 1B studies, so they're not blind randomized clinical trials. So I don't think that the PRPP literature right now is a gold standard per se. And there's going to be a lot more. There's only 5 studies right now that really are of any value at all. And then from a bone marrow aspirate perspective, there is similar. It's the same idea. There's studies that are out there, but still no really good 1B studies that are out there right now for this. I think they're going to be coming out. There is a 1B study that's being done right now. Some of you have been involved with some of the stem cell studies, and those are also 1B, the randomized blinded controls. 5X is a company that's using an allograft. This is an interesting material. So it's an allograft type of BMAC, if you will, but they actually take intradiscal allograft. So the disc, the nucleus, they take that material from cadavers, process it, mix it with a scaffold from a bony scaffold that's also allograft, and they're injecting that into the disc. But this is the first allograft BMAC, if you will, that's being studied. This data is going to be out in the next 3 to 4 months. So I know that was more of a software talk. We did a lot of hardware this morning, but that's a bit of a software talk. I think it's useful for us to understand some of these simple terms and to understand what's happening out there. For every spine surgeon, there are 17 pain doctors. Some weird average that I know, right? So if they're really becoming more and more active in this realm of back pain treatment, and some of the stuff, like I said, there is some validity to what they're doing. Some of it there isn't. But if you're in discussions, if you have pain management people in your group, or if you're going to hire pain management people in your group and things like that, it's interesting to just kind of understand what this is going on right now, because it's, like I said, we don't want to be the Palm Pilots too fast here. All right? Does anybody have any questions about this? I know there wasn't. Yeah, go ahead.
Yeah, so that's great overview, but there's a lot of guys in DC doing this, right?
Mm-hmm. Yes.
Advertising.
Absolutely. This is exactly what I'm saying. Exactly.
Well, they're harvesting people's bank account in addition to their bone marrow.
Correct. And I have all the I didn't go into the survey that I did included a lot of the financial. Yeah.
This stuff into people's discs, vacuum disc, chlorotic disc. I mean, what is the, I think what you're saying is on point. I mean, we don't want to be left behind, but there's absolutely no literature that's.
Yeah, so the BMAC literature right now is growing. There are some prospective studies that are out there that are showing some of the validity and the utility of this procedure, but the payers are going to be far behind. And then from a CPT perspective, right? The AMA requested me to be ahead of the game. So they want there's a CPT category 3 code that's going to be there's an application that's going in this month for this procedure.
Aren't these all cash practices with this right now?
That's right. Right now, there's no CPT code. There is no CPT code, right? We're all familiar with CPT codes, right? But in 1 or 2 years, depending upon the cycle, so the application is in now, right? So the application gets accepted in 3 months. And then if it makes that 1-year cycle, this could be a CPT code for this procedure, could be active within 2 years, okay? That changes things, right? When there's a CPT category, it'll be a category 3 code, but still, that's still gonna change things. And you'll see an evolution of, the biologics are a much, it's significant, we all need biologics in our procedures, whether we're doing fusions, whether we're doing stem cell injections, the biologics are part of the procedure, right? You can't just put the metal in, right? There's the biology that's the most important, right? And so these technologies are not gonna go away, no matter how much we complain about this and the price and too many doctors do it, right? The biology is there, and whether it's right or wrong is hard to, it's hard to prove right now, but that's where it's headed.
What are the ethics of, what's NAS that has a, membership that includes pain management and
Yes.
doctor's fine? I mean, what are the ethics? I mean, I see my poor patients are paying $10,000. I had last week, it was a classic case. Guy comes in and goes, I paid engineer, intelligent gentleman.
Yep.
And a blue collar kind of, white collar guy, but $10,000 for stem cell injected in his greater throat cancer
For bursitis, absolutely.
by a pain management specialist. He's part of an HMO, so the same pain management outside of the HMO contract, $10,000. Turns out he has basically an L5 radiculopathy. So I send him back to that same pain management person for an L5 nerve block that cured that pain.
Yeah.
And it's amazing. They're not even upset because I think they feel so guilty. They spent so much money that when it doesn't work, they don't even get that angry. And so
Well,
where do they have
this is why I bring up this topic, and I'm glad that Sig and Fred
infuriates me?
Fred asked for this topic to be talked about, because the more you know, the more you can help your patients understand what this is about. Because right now, a lot of us, right, don't understand this technology whatsoever, right? We didn't know what a mesenchymal stem cell was until 10 minutes ago, you know what I mean? And so now you have to be aware of what's happening, and you have to help your patients. But you're right, the ethics here, there's a gray zone that's occurring right now in this world of, this technology. And like I said, some of it's going to be valid. I think it will be. It has to be, because from a biology perspective, you are introducing healing properties, into this avascular sort of environment. So, but yeah, it's a good question.
All right, Jim. Well,
All right.
Thanks so much for rounding that off. So this session really covered a